Toussaint. Hello, Toussaint. Please, is the screen being shared?
Yes, sir.
Okay, thank you so much. I'm going to start the class. So I'm recording. Please take note of that. All right, guys. The other time we started with the GIT and we were able to cover a couple of topics. So we went briefly through how digestion actually works. And then immediately we finished, we started with bleeding. We got to know that bleeding can occur overtly or occult, as in hidden or seen. And we divided the GIT into upper GI and lower GI. So from the esophagus to some early parts of the duodenum was the upper GI. And also from the small intestine after the duodenum, large intestine, rectum, or the anus were the lower GI. We looked at the causes of such bleeding, and we got to know properly some terms like hematemesis. So emesis means vomiting, and if a person is vomiting blood, the color of the blood can give us a clue where it might be coming from. Yeah, I mean, it's mostly for hematemesis, mostly it's upper GI, but we could still have a situation where we can say somebody is vomiting deep down there. It's very possible. Then we look at melena, with melanin being our trick for black tarry stools. Then hematochezia being fresh red blood. Okay. And we spoke extensively about colonoscopy and what goes into that and what not. We did peritonitis, and one cardinal thing that sprang up was the board-like abdomen, rigid board-like abdomen. It's one of the cardinal signs that will make you know that no, we are talking about peritonitis. And we said most of the abdominal conditions will have that as let's say a complication. Okay, we'll have that as a complication. So we looked at all of that, and there is a trick and trend with which we're doing things like mostly when individuals were in such situations, we will put them MPOY because there's a likelihood of surgery. And because we're not giving them orally, we hydrate them, give them IV fluids, antibiotics. We manage the pain that is with the condition that they're having, and we prep them for the possible surgery. So we looked at all of these, and today we are here. We're going to look at bowel obstruction or intestinal obstruction. Most of the time it's the intestine. So I'm going to start, and what I want you guys to know is that bowel obstruction means something is blocking food, fluids, or gas from moving through the intestine. It can happen anywhere in the GIT, but most especially we are looking at the bowel, which will be the intestine, okay? So we are looking at the small intestine or the larger intestine. Now, before I do that, let me ask you guys a question. What do you think can make a person's abdomen, is it the word swollen, big, or enlarged?
Hello, sir.
When
The person has ascites
or become big, what can cause that?
Ascites. Hello, sir. Ascites can cause that.
Am I being heard?
Yes, we can hear you.
Something wrong with my network. Yes, sisters.
We can hear you.
Yeah, I know the 6 Fs or 5 Fs. I don't remember all, but I know 4.
Sisters, are you saying something? Guys, can you hear me? I just want to be sure.
Yeah, we can hear you.
But we don't know if you can hear us.
Can you also hear me, please?
Oh, then it looks like there is something wrong with my. Oh, I'm so sorry. Let me ask you guys again. I'm trying my equipment. Can you guys hear me for the last time, please?
Yes, I can hear.
Oh, I'm so sorry. I cannot hear you guys also now. So probably you guys were answering and I was just shouting. So what are some of the courses, please? I'm listening to you guys.
So can you hear me, please?
Sir, I can hear you, sir.
Yeah. So what I know, I'm just sharing what I know. So I have the 6 Fs. I've
Good.
forgotten most of them. We have the food, fluid, fat, fetus. I've forgotten the remaining 2, but I know it's
Yeah, take your time.
4.
Let's analyze it so that others can help you. I love the Fs. Can you take it again? You said
so we have like food,
okay.
fluid,
feces. Good.
Yeah, fetus, that is fetal.
Fetus, that's a baby, right?
Yeah, and yeah, I think that's all. Yeah, flatus.
Somebody said flatus, which is gas.
Flatus, yeah, gas.
Any other F?
So,
somebody said the fact that you're a female. I don't know what the person meant by that. But basically, this, ladies and gentlemen, that was a very good one. Let me applaud for them. And this is one good way you can actually memorize it. So if the question is registered that a person's abdomen is enlarged, is swollen, whatever term that they use to describe it, these are the Fs that should come into your mind. But there is more to it. There could be a growth in there, right?
Yeah.
Tumor, but we need to convert the tumor to F. How will you say?
Fibroid.
Fibroid, I'll take it. Fibroid, yeah, I'll take it. This is one good example. Good. All right. Any other thing anybody wants to add? All right, let's move on. So we have different types of the obstructions, and you look at them, okay? Yeah. Now, with the obstructions, we have what we call mechanical. If I'm talking about something mechanical, it's like I've come to you and I'm squeezing you physically. But if it is not mechanical, then it could be something like physiological, anatomy and physiology, how a structure is supposed to function. So, for example, if you have what we call paralytic ileus, in other ways or in simple ways, let's say your bowels are no more moving, they are paralyzed. And the wisdom is that there are nerves that should control them. There are certain structures that should help them work. If those structures do not work, if their physiology is not working, you will have an obstruction in the flow of food because there's supposed to be a peristaltic movement or whatever, depending on which aspect or which place of the GIT you are in. Okay. And sometimes maybe surgery, infection, electrolyte imbalances, even medications can cause that. Like, for example, when you take opioids are notorious for causing constipation. And so when you take too much of opioids, you see that intestinal motility slows down. And to a very extreme case, it becomes as though your bowel is obstructed. Now, we are talking about the mechanical ones. The mechanical ones, you can take it from the perspective where a bowel is twisted. A bowel has entered the cubicle and it has locked it. Okay, there is a tumor pressing on it. It has telescoped into itself, that is into succession. We will look at them. Or maybe a stool so large that it has imparted. Yesterday or the other time, I spoke about this aspect of the large intestine. If you have too much water flowing in there, you get diarrhea. If you have less water going in there, you get constipation. It just should be a moderate and accurate amount to make things okay. Okay. Now, we are going to look at the signs and symptoms, the signs and symptoms. And I'm going to group them into if it is the small bowel and the large bowel. When I say small bowel, what am I talking about?
Small intestine.
Small intestine, okay? And that involves the DJI. I don't know why I always recall DJI. What goes into the DJI?
Duodenum, jejunum, and then the ileum.
Thank you. Very simple. Duodenum, jejunum, and ileum. DJI is like, there is this drone camera. They've made it like a small helicopter. It flies there. And there is a company that's called DJI, something instrument. And I don't know, I'm able to recall the name of that company also, and it stays with me. So if it is with a small bowel obstruction, then there will be a sudden cramping and then abdominal pain. The patient will vomit, but the vomitors may be greenish or fecal smelling if severe. Do you know what is happening? It's like whatever you've ate is choked. It's not going away. So in the worst case scenario, it will come through the wrong route. And when you bring it out, we know that no, this is not the smell of, excuse my language, the usual vomits. This is a little bit something weird, right? Some of them greenish. You see that it's been there for a while. And because there is bowel obstruction, there will not be any gas. The patient can't pass gas. This is among one of the reasons why after a GIT surgery or surgery in general, when we put the person's system to sleep, we would want you to at least pass bowel before sometimes we try feeding you. Because if we feed you and your bowel is not responsive, you are just going to pile up. And that is one of the reasons. So this can also lead to abdominal distension because the thing is not growing. So whatever you are adding up is going to distend your abdomen. And we have in the early cases, we have a high-pitched bowel sounds. And then later there is no sounds at all. High-pitched bowel sounds and later there is no sounds at all. So what is happening is, assuming in the early stages, the thing is piling up, maybe there's some small hole along whatever is being blocked. So when there is movement and when you listen to the, what we call the bowel sounds, you can see that maybe some AB is trying to pass through one of some weird space be around. So you can hear a high pitch bowel sound. But then as time goes on, you will not hear any bowel sounds at all. Now, let's look at that of the large bowel obstruction. But before we look at that, can you, whether you look on the screen or not, tell me some of the signs and symptoms of small bowel obstruction? Let me hear from you.
Vomiting. That will be greenish
Okay,
and
any
has
other?
a smell of fecal matter.
It's
Abdominal
also
distension.
sudden cramping, the abdominal pain.
Abdominal distension and then cramping. Yeah, guys, you see, when the students chorus like that, I'm okay with it. Sorry if it sounds chaotic for you, but for me, I am okay. I'm able to decipher what they said. I don't really care much about that. I know it would have been nice if you let them raise it. Yes, I mean, that is the formality of doing things, but I want this inclusivity. In those days, ancient Spartan, they practiced that kind of thing. It was a very realistic voting. 100 people come. Let's say if everybody is voting, you come. Then we say all those in favor of the motion say yeah, yeah. Then we look at the magnitude, the strength, the velocity, the heaviness of the sound. Then we ask those who are not in favor say no. So that one, the person you are voting for is looking at you. You can't lie. Not today, politics. You go and secretly you take my money and you go and vote against me. So that was it. I think some show business guys, some MCs do that. Have you observed that, like in one of those dancing competitions, somebody will say, "Stay away." Have you heard that before? Yeah, they do that. It's a way they train. There's a way we call it. It's a type of democracy. I've forgotten it. Okay, all right. So don't be bothered by it. Those watching on YouTube, today's Mother's Day, so I gave you the chance to watch with us. Don't forget to subscribe if you have that chance. All right, let's look at the large bowel obstruction. Unlike the small bowel obstruction, this one is of a gradual onset. A gradual onset. Akuz, do me a favor. chat on the page that I'm streaming live on YouTube. So if anybody's free, they can join us. It's just a Mother's Day package for women. Okay. So the large bowel, the onset is gradual. And for the small bowel, it's sudden. So if I were to ask you for the trick between sudden and gradual, how will you record that the small bowel one is sudden?
With the S.
It starts with the S. It starts with the S, making it very easy. And with this one, yes, mostly constipation, and may pass gas at first, but later the person wouldn't pass gas. The small bowel one, the reason why I get the small pitch, that high pitch, is that in my mind, I create a small space between, excuse my language, let's say food is trapped in your small intestine and there is a small space. So if air is trying to go through, it will make a high pitched sound. That is how I have pictured it in my mind, just so I can understand and answer questions with it, right? But when you get to the large bowel, then I talk about constipation. The patient may pass gas at first, but then the motility loss is lost, so the person don't, and your abdomen can become distended. What is cardinal through the two of them is that in all cases you are compiling, so you have a distended abdomen. And if you compare the nature of the pain, obviously that of the small bowel movement, small bowel may be a little bit higher as compared to where the location of the large bowel is. Okay. So that is that for it. Now, how do we intervene? How do we diagnose it in the first place? So we can do an X-ray. An X-ray may show maybe air or fluid or air fluid levels or dilated loops telling us that things are being packed up. A CT scan is even more accurate to help you actually locate the blockade. And we have a couple of electrolyte tests just to see what is going on with the vomiting and all that. And then we can rule out any infectious process and see what is going on with the person in terms of rechecking the white blood cells. Okay. Now we have a non-surgical means. Sometimes they just relax your bowel and they call it conservative treatment. Please, have you heard of that before?
Yes, sir. Yeah.
Yes. It means they're trying not to touch you. They're not going to cut you. Maybe sometimes conservative may mean with medications or maybe symptom control, right? And sometimes they will just need surgery to do it. And normally they would indicate that if they think there is an ischemia, in other words, if they think whatever the blockage or wherever the blockage is, it's not causing or it's not helping with the delivery of blood to other parts of the intestine or the GIT, then they wouldn't waste time at all. They will go and take it out. Now, for you, the nursing priorities is as usual. If you take your time and study the pattern with which we'll be going in, you see the same thing. Cynthia, assalamu alaikum. I see your face. Okay. Now, for the intervention, first of all, MPO, nothing by mouth. How many hours normally do we put patients nothing by mouth before surgery? You can give a range.
6 hours.
8 hours.
6 to 8 hours, good. But with this one, even if they are not preparing for surgery, you still will put the patient MPO. And normally when you put the patient MPO, you're supposed to hydrate it. So you give what?
IV fluids.
IV fluids. And then if the things in the stomach are not helping, sometimes they try to decompress. And so they pass an NG tube. This particular type of NG tube, when you see in the US, in magnet hospitals, most of the time, it's like a coordination between healthcare teams. Before a transfer is made between a patient, what we call trans in and trans out, where I'm coming from. In the US, yes, you can also trans in a patient or trans out a patient. And then you can admit a patient. We use admission if the patient is coming from the ED or the emergency room or emergency department, whatever you call it. Now, before they come, they're supposed to call and give report. Now, when they are giving the report on the patient, you are to look out for certain things. Those things include you checking to see if the patient is actually right for the department they are bringing. There could be something that needs to be addressed there in the emergency before they even bring the patient up, right? And it also gives you a clue what you're about to do for the patient, what to set up ready before the patient comes. Things like oxygen. And even with this one that the patient is coming with an NG tube indicated, looking at the nature of the condition, if you are, excuse me, smart enough, you see that no, they will decompress. So I will get something that will transfer whatever they are decompressing into. They will have a canister, they call it a canister. Sometimes it's connected to suction, a continuous suction, or they will give you the instructions. Some of you have not seen that suction before. Before I came to the US, there was a suction machine and it was manual. When you want to suction the patient, you go in, you suction, and you come out. That is fine. There is this other aspect of a suction machine where in the US, you see the walls in the hospital. Most of our walls have oxygen unit, maybe air, and then they will have a suction unit. But most places in Africa, the suction units are not working. But other places, they are working. The hospital that I work in, I could see the suction was working. But sometimes you even lack the device to use the I mean, this is just because we have lots of low and middle income countries there. But even with that, there are very good hospitals around that have some of these amenities. So when you come, you see this on the wall. I'm teaching you as somebody who is coming to the US to actually come and work, right? I'm teaching you as somebody who understand whatever is going on there. So I'm preparing you for the job at hand. Okay? And so when you come there, you will see that suction tin. Sometimes there is a space for you to put a bowl, we call the canister. You put it there, and then there is a suction device. We have different modes of the suctioning. We have continuous, means it's always suctioning. Then we have intermittent, okay? And then apart from that mode, we also have other functions of it where it could be, even if the continuous, it could either be high or low. So low continuous or low high. And then sometimes they will say low intermittent. So the suction is low intermittent. And for most of these GI conditions, it will mostly be a low intermittent suction. So sometimes doctors, when they even forget themselves or anything of that nature, when you call, you make the work easier. You go straight to the point. Look, the patient is in. I've connected to the suction. How do you want it? Is it low intermittent suction? Say yes, low intermittent. So the doctor just said yes, and it was done. Either than the doctor saying, okay, let us put the patient on a low intermittent suction. Compared to the yes, I think your yes was fine. I mean, it makes the work easy. It makes them feel you know what you are up to. But always ask them so that they put in the order, okay? So that you are covered. Don't do it without their orders. Anything can happen. Then straight intake and output. In fact, the patient is not going to even intake anything, but then we are going to consider the IV fluids that is going in as an intake. Guys, are IV fluids intakes?
Yes.
Yes. Yeah. And so you watch for signs of perforation in case the thing perforate a paya. Oh, what will happen? And then if it perforates, we are looking at which condition? Most of the time. Peritonitis. And what's the cardinal sign that we spoke about? The trick we used?
Rigid abdomen.
Like abdomen.
But, all right.
Rebound tenderness.
No, it's part of it there, but the rigid board like really works on the board's assistance now. Okay. For the rebound tenderness, there will be a couple of conditions, appendicitis and others that will come with the rebound tenderness, but your ability to see the rigid board like is a huge thing. So for the NCLES, high-pitched vowel sounds come early as the obstruction tries to move contents, and then later it becomes paralytic most of the time. So for small bowel movements, small, what was the S that we use for? Sudden, right? We said it occurs suddenly. And then the large bowel one will occur what? Gradually. Some of these things, it's not nice studying them, but if you study them in a group like this, it stays better. So suddenly and gradually. Then with the gradual one, it will come like maybe some constipation, be with something, but later you don't have even a bowel sounds. But if the small bowel movement, you will get a small sound. So high pitch sounds, right? High pitch sound, and then later it turns out. No matter what is happening, never give laxative for animals in a complete obstruction. What it's going to do is that it's just going to increase the pressures and maybe even rupture the abdomen. Always monitor for the complications, which will either be peritonitis or signs of shock. This is what mostly the boards look out for. And sometimes when I'm teaching like this and I share publicly, I feel like, hey, those who said the questions, when they come and listen to me, wouldn't they change the ideas because I simply said that's what they're looking for? So they're going to look for other things. No, they wouldn't change it. Medicine is medicine, and it has remained certain level. Unless we have discoveries, and of course, it's dynamic, things change, then we have things changing. Apart from that, if this is the approach we approach something, then we keep approaching that thing in that regard. Let me see you answer this question for me. Remember, I said no laxative for animals. And then you watch for complications. I will look for just 5 answers. We don't have much time. It's Mother's Day. We need to make our women rest. So obviously, people are able to pick. You know, some of these questions, when you leave yourself for 2-3 months and then you are going to write, probability that you recall goes down. But with the tricks I've given you, I hope it stays with you.
Yes, sir.
Let's try this question. It's a select all that apply. Please, those on YouTube, if you've not subscribed, subscribe. I don't even know why I'm begging you guys, because we're supposed to help each other. But these days, I must acknowledge whoever is doing that good job for me. All of a sudden, I'm getting good subscribers, I'm getting great watches, and I'm on the route to monetizing it. And when I fully monetize it, I don't think there will be the need to take anybody's money for classes anymore. I'll just teach. Yeah. Or maybe I'll just stop teaching one video at a time so that I have my rest. What is this thing about select all that apply? Can we reiterate what we have to know about select all that apply?
Yes, you pick answers you are sure of. If you are not sure, you shouldn't. Else you'll be deducted marks of what you've answered.
Good. Good. So if you're not sure, if the question is plausible, like you're not too sure about it, just don't. Now, are we going to pick abdominal distension? The answer is what?
Yes.
What about bloody diarrhea?
No.
No.
Vomiting with fecal odor?
Yes.
Yeah.
Yeah.
Now, for the sake of the people on YouTube, if you know your background is not that good, I would advise that you don't really open your mic, because when you open your mic, you give us some terrible feedback. I'm sorry about that. But yeah, it is what it is. I hope I don't break when I talk. Do I break or is okay?
Sometimes.
It's okay, sir.
Somebody said sometimes. Do I break sometimes to some of you?
No.
Okay, so the one thinking I'm breaking, maybe could you check your network too and see?
Okay.
Yeah, because if a couple of people are saying I don't break, then it means that the one hearing the break is coming from your end. Okay, because I was thinking I'm breaking anyway, and the reason for me saying that is that I see that when I talk sometimes it cuts. That's why I was saying that. Yeah, but I hope you guys hear me so well.
Yes, sir.
Okay, all right. So, what about vomiting with fecal odor?
Yes.
Yes, it can
Yeah.
happen. It can happen. Somebody said the minimal glitching though. Are you guys experiencing the minimal glitching? Please let me know. I need the feedback because I'm
No,
recording.
I'm not experiencing anything. Thank you.
Anything? Any other person not experiencing anything? Any hitches anywhere?
I'm also not experiencing anything.
Okay, so it means if you're experiencing a minimal glitching, then it's minimally from your side. Yeah. All right. Just so you know, and you can position yourself and you don't miss anything at all. Now, hypoactive vowel sounds. Is it going to happen?
Yes,
Yes.
sir.
Is it not ambiguous? How does the small vowel operate? Like they said initially, there will be what?
There'll be high
There'll be
pitch
no,
vowel sound.
And then
High
later,
pitch, then later, no vowel sound.
okay, what about the large two? Constipation, right?
Yeah,
And then later,
no vowel sound.
no vowel sounds. Is hyperactive vowel sounds a replica of no vowel sounds? Is that what it
no,
means?
no.
What would be a
No.
oh? In what ways can we say no vowel sounds? What would be the technical way to say?
Would you say absent?
No gas.
No.
Absence of vowel sounds.
Is there no technical word for it?
Not really.
Not
We've not.
really.
Yeah.
It's just called absent of vowel sounds, right? Okay,
Yeah.
maybe I will search for a word for it. But we have hyperactive, and no vowel sounds.
Hyperactive would be.
Say again.
See, hyperactive, I think, is what they call borborygmi.
No.
I'm not hearing
Papa.
you well. I'm not hearing you
I
so
should
well. If you're using
prepare
an
hyperactive.
earpiece, can you take the earpiece out and speak so that members on YouTube can also enjoy you?
I think what she said was hyperactive is what I say must read me, but I disagree.
you,
Not
you have
hypo.
Yeah, you're not
you
the
have
I
same.
every
said
right to disagree
hyper.
anyway. Yeah.
I said
Sisters,
hyper, not hypo.
she said
Okay.
hyper, not hypo. She's clarifying for us.
Oh, okay.
Yeah. Sisters, you have something to say?
Sorry, it's been answered. I
It's been
wanted
us.
to, yeah, speak to the borborygmi. It's a normal bowel sound for the abdomen is a borborygmi. But for the hypoactive, it means that it says the activity of the bowel is low. It means there is something ongoing or ongoing. So hypoactive, low active bowel sound. So that's the
What
so
is
it's
this one? Have you heard of this one too?
yeah, that is normal.
Okay, no more active. All right. I'm not going to add the D. What do you think? Please argue your point out. Are you going
Yes,
to
I
agree with
agree
me?
with you.
Okay, to be on the safer side. Who else? Please, somebody to argue your point out. Do you think you pick it? Because I think it's ambiguous. It says suspected. Okay. So if
Exactly.
somebody is having just hyperactive bowel sound, even if you're constipated, you can have hyperactive bowel sound. So it means that you have a small bowel. It's not strong enough, right? Because we want a symptom that was supported. Yeah, sisters, feel free. Don't worry
Yeah.
yourself with the raising of hand. I know
Okay.
you are very
So
good.
I will support a hyperactive bowel sound because, as you said, it says suspended bowel obstruction,
Yeah.
which means it could be lower or larger. And both
Okay.
the symptoms we are looking at are for both small and large intestines. And
Okay.
if there's a hyperactive bowel sound, it means there's an obstruction ongoing. Because
Okay.
as we already mentioned, the normal bowel sounds is logarithmic. We at least it's not hypo and it's not hyper. So if it's
Okay.
hypo, then it means there's an obstruction. That is why it is going low. So
Okay.
it will, at the point there's no vowel sounds, but I
Yeah.
have to start somewhere
Yes.
to hypo, then no vowel sounds. So I'll pick that one.
You
It's
support it.
part
What is
of
the
it.
difference between constipation and bowel obstruction in your own words or however you understand it? But in constipation, there is little fluid in the colon, right? And it's like the feces is balled up and it's quite difficult to bring them out. Sometimes they become a little bit right up there. Sometimes they can block or obstruct the bowels sometimes. But the only time we will change from it from being constipation to bowel sounds is that bowel obstruction is that with the constipation, we can visualize what is happening out there. It's not mechanical or any of those even non-mechanical ones that we know to support it. You can even give laxatives and the patient will just relieve. You can give animals and it will work. Will you give animals in small bowel or bowel obstructions?
No.
No, you wouldn't. So there's a great difference there. So if I were to even look at that intervention to differentiate between constipation and bowel obstruction, I would say that with the bowel obstruction, the doctors won't do this. This one, they will do that. But here's the case: we are looking at a symptom rather to support. So the catchword here is support. Hypoactive bowel sounds can support constipation and it can support to some extent small bowel movement. But if you really want to diagnose it, I don't think hypoactive bowel sound is a strong thing for you to look at. One cardinal thing between hypoactive bowel sounds and the absence of it, I think if there is no bowel sound, then I'll conclude that it is a bowel obstruction. Otherwise, what is going to happen with hypoactive bowel sound is that I'm rather going to have what we call differential diagnosis. Guys, do you understand what we mean by differential diagnosis?
Yeah.
It means that it could be this, it could be that, it could be this.
Something else.
So what will support it? Then you come to the question. Then you pick what exactly will support it. Whilst this is good, I don't have enough faith to pick it. But I wanted you guys to kind of buttress it because it's not wrong an answer. Guys, do you think so? It's not wrong, right? It's not really wrong if you understand what is going on. But it's not part of the answers anyway. Let's try this question. And if you're in my class, never ever feel defeated when you get a question wrong. I don't care. When I was practicing for my English, the question bands that they brought me, I was always scoring 40 and whatever. As biological wife, I never scored above 45. Always beneath 50. But I was learning through it. Those scores, they don't really determine what is happening there unless you don't learn from your mistakes. So make these mistakes here. And sometimes the questions, whether it is right or wrong, depends on their marking scheme. But the wisdom in answering the question or understanding what is going on is what I want. And I like it when especially I get constructing views and students are using that intellect to argue it out. I love those type of critical thinking abilities. Okay, so people are saying we should administer oral laxatives. Okay. Let's try this question.
Hey, so it's not administer. What you question?
Yeah, yes, I am aware.
Yes.
It was looking for the wrong one, right? Thank you for drawing my attention to it. But I was really aware it was looking for the wrong one.
So, Asabe, please, can you go back to the previous question so that I check something real quick?
Okay, I'm going to show you just the question and not the answers. Will you be okay with
Sure.
that?
Sure, no problem.
Wow.
Thank you very much.
You're welcome. And thank you for sharing that thing on the page. I saw you do it. Thank you so much. I appreciate you.
Welcome.
So what's your answer, guys?
Sudden sharp abdominal pain.
Rigid abdomen. B.
B. What are we thinking of?
Peritonitis.
You are good. My boys are good. All right. Let's go to another aspect of it called volvulus. Vovole, vovome, dela yesu tomenye. If you are entangled, you are not free. Those airway people, what do we mean by vovome?
Free. Vovome is free.
Free, yes. Being free. So it helps me even relate to volvulus. I don't know how it clicks, but I'm just able to turn my mind to you that volvulus means you are entangled, right? There's a mechanical thing there because of that airway music, which has something to do with liberty, being free. Okay. This one is an example of a mechanical obstruction, and it's twisting of the intestine, and you can see the images I've tried to demonstrate for you. The upper one is really exaggerated, but I mean, it is what it is. Okay. Guys, can you see the twisting?
Yes, sir.
Yeah.
Yes,
And
sir.
it can happen in the small bowel or even in the sigmoid colon. That's the large bowel. And this one, like this, it will lead to ischemia. Do you think it will lead to ischemia? The way it's
Yeah.
turned like that.
Yes, sir. It will.
Oh, so there will not be blood supply. And so if blood supply does not go to a place for a long time, what will happen?
Necrosis.
To die.
It will
To
die.
die.
Okay, all right. Now, let's look at what will cause that. Sometimes it's congenital, the child was born with it. Or maybe adhesions from prior surgery, they've been cutting things and all that. Or chronic constipation, the thing has been constipation has happened before you see twistings. You say you want to go and poop. You try turning the intestine, turning it before you see it's twisting things down there. Then we have intestinal malrotation, the thing turned the wrong way. For your symptoms, we are getting a sudden severe abdominal pain. Of course, could have a distended abdomen, and you vomit. And the cardinal thing with these bowel obstruction stuff is that when you are vomiting, you are bringing what you have in out. So it smells. You wouldn't pass gas. You wouldn't pass stools. And sometimes, because of the ischemic nature of it, you may present with signs and symptoms of shock. Signs and symptoms of shock. Now, when we do an abdominal X-ray or CT, there is something that we see there. We call it the coffee bean sign. So on the anklets, they will ask you about this, the coffee bean. Okay. Now, let me be very blatant here. And sorry if it raises emotions with you. In fact, Ghana raised the emotion for the world to understand that slavery is the worst crime ever any human could offer to another human being. And I also kind of subscribe or agree to that phenomenon. And what happened was that most of us were taken to work on plantations in Brazil. Some of them were coffee. And you remember the song Vovome, which is talking about freedom in Ghana. Okay, it's a Ghanaian language, anyway, very nice language. And that thing is talking about. And volvulus is talking about twisting. Volvulus is talking about twisting. So you think of the entanglement, you think of the chains, people in chains. I don't know how it works for me, but that's how I've associated it. And I think of them going to work in a coffee plantation. So when I see the coffee bean shaped thing being discussed, I know they're talking about volvulus. It works for me. I'm sharing with you. It may or may not. You can also have something to relate to. And when you talk about the bean, coffee bean, guys, can you see this part?
Yeah.
And it's shaped like this. You see that kind of thing in the middle of the coffee, no? Sometimes when it's quaint like that, you see those kind of shapes also here. So that is what they are saying. It's not huge. It's not too difficult. It'll be good to go. Of course, it's a bowel fashion. So the usual thing we do, no, keep the bowel, let them rest. Okay, MPO, just in case they will do an emergency surgery, which they have to, because in this case it's ischemic. And in a prioritization question, when this one falls in, you should know that it's quite urgent. IV fluids and electrolyte replacement, that is done. You are keeping the patient MPO, so you replace it. Even if not for the MPO, the patient would have already not been able to keep anything down there. Patient is already in pain, struggling, and it's not even eating well because there's sometimes no absorption going on. Give antibiotics if it's been ordered, and you are monitoring for complications, which our favorite one will be peritonitis. And over here, the huge one will be septic shock or shock in its case because there is ischemia. Now, for my tip I'm giving you, if a patient has sudden severe pain, distension, vomiting, nose too, suspect volvulus. Okay, suspect volvulus. I mean, the conditions, they look alike. So on the next generation type of question, they will present that the patient has a sudden severe abdominal pain. There is distension. There is presence of vomiting of foul smelling feces like emesis. Okay. Then they will say that bowel sounds, the patient had high pitched bowel sounds at first. Then they will go to the next page. Then they will tell you which of these will be present in the following conditions. They will bring the various form of bowel obstructions that we have. Okay, then you are supposed to make some of them out. Now, for me, the volvulus, I'll use the coffee bean shaped thing on the CT as a heel thing. And also, normally when it talks about stool too much, I'll try for the volvulus. And when it mentions ischemia, I'll also go for the volvulus most of the time. The last one I will talk about, and then we'll close for today because it's a special day for our women, is intussusception. Now, intussusception is when one part of the intestine slide into another part. We use the word telescope, so it telescopes, telescoping of the bowel, and this also can also block blood supply and movement of things through the bowel itself. Sometimes the cause is unknown. It's as though nature came to you, did a natural operation, and pushed things inside, but it does happen. It's most common in children under age 3, sometimes linked to viral infections or intestinal polyps. So, of all that we've mentioned concerning the bowel obstructions, which of them is common in kids?
Intussusception.
Intussusception. Yeah. Now, the symptoms, which is mostly classical in children presentation, there will be sudden intermittent abdominal pain. The child will draw the knees to the chest. Mm. And then there will be a red currant jelly as describing the stool. That means it's mixed with blood and sometimes mucus. There will be vomiting. And if you want to palpate, a sausage shaped mass will be felt in the right upper quadrant. Mm. And there will also be lethargy or altered consciousness in severe cases. For intussusception, the wisdom is to associate it more with children, understand that it's telescoping, and then there is the aspect of the diagnosis where we do an X-ray or an abdominal ultrasound. They call it abdominopelvic or abdomen and pelvic scan. When they do it, you are going to get something that looks like what we call the target sign. So I try to use fake images to depict it. Guys, can you see this?
Yes.
Yes, sir.
Have you seen the target I'm talking about? What the archer uses?
Yeah.
Yeah. Okay. Now let's go back to the previous pages. When somebody had a small bowel obstruction or large bowel obstruction, were we going to give enemas?
No.
No.
But with this one, we are going to give what? Air or barium enema. So that makes it special, right? So instead of learning everything to kill yourself, you can see those that make things special. Now, another thing about the word is that it's intussusception. So it's the one that you push things into it as well. It's the one that you push enema in there. It's the one that you push air in there. Just so that it will, if you're lucky, it will split them out. Pressure. It's like a balloon when you put air, then it straightens things out. Yes, of course, it's a small bowel obstruction. The method has been the same. First, I was thinking of how will I keep this? But when I started researching, I saw that it was still MPO, IV fluid. You monitor for the bowel sounds, any other symptom that come with it. You, of course, monitor for signs of complications, okay, including ischemia. Prepare for the animal reduction or surgery, and then monitor for reoccurrence if anything will occur again. Let's answer this in the chat box.
Okay. Yeah.
Okay, so people have answered. They chose C, and I think C is correct. Let's try this. All right, people are choosing B, sausage-shaped abdominal mass. Where is it mostly palpated?
Right upper
Right
quadrant.
upper quadrant.
Right upper quadrant. There is a famous organ there at the top there. Which organ is famous and popular there? The liver. Okay. The liver, right upper quadrant. The liver is very, so mostly it's there. But when they talk about the right lower quadrant, which organ do we normally point to?
Appendix.
The appendix. The appendix. Sometimes some of these things, it's not things that average student learns. But I am the president of the Average Student Association. I've learned it. So, Oga, I beg this one, you don't have excuse. Right one is the liver. Okay. And then the down one is the appendix. In fact, appendix is quite easier to know that it's easy because appendix is mostly down, right? When you write any scholarly document, you put your appendices at the end of the document, don't you? Right? The appendix A, appendix B. So it's down, right? Lower quadrant. You just learn with associations and you're pretty much good to go. Let's answer this question. So this time again, I will see how people will defend the E. Okay, people have answered, and most of their answers were A, C, and D. Let's try this question. Practice, they say, brings about perfection. So let's practice. I'm encouraging you to try my question bank. My question bank do not have easy questions like this. Oh, yes, it may have. When you are, please, those who have purchased my question bank, when you are selecting the questions, we have difficult questions, medium difficulty, and then easy questions. They have levels of difficulty. So make sure you know what you are picking. Don't just oversight it. And I have a section I've called Asabi. It contains about 900 special questions. Answer it and thank me later. That is what I'll tell you. I can, just to make it easier for you to know that it is something I'm giving you. It's not past question. No, I've not said that. Please, the one type of no. I did not say that. But it's not past question. There is no past question on the English. But just go there, answer them, be confident. Today I was working on ECGs. I'm putting ECG straight there. I'm fine-tuning it. I'm making it better. I've added stuff from pediatrics. Go and solve them. No question bank will give you that too. Most of the question banks, the higher the number of questions you can solve within a set, the more amount of money you pay. For me, you are solving almost 4,000 questions. Listen, 4,000 questions. And yet my price is even the cheapest in the market. Mine is half of that cheapest. And it does not mean that my question is of lower quality. I've dared you, if you like, tell me that you're going to use it strictly for 3 months, like you are preparing for NCLEX and you're going to use solely my question bank, 3 months preparation, and tell me that you will not pass. Unless maybe, I don't know, but to be honest with you, with what I've put out there, I'm 100% confident that anybody who goes with it for 3 months I've been doing this for long.
Mm.
I've been doing this for long because remember those days, I'm not supposed to be seeing this on recording, but I was helping students buy Archer. When you help a person buy Archer, it means you also have access to that logins. So I use Archer, I use UWorld, I've used Bootcamp, I've used nursing.com, I've used Nurse Achieve or whatever they call it. I've used them because my students were having them. And some of them, sometimes when we are learning, some of them share the questions with us and we solve together. And I've been through it over and over and over and over. I've seen the patterns. Then I went to the higher stages where I've attended so many webinars. And these webinars were on item writing. Let me tell you guys, things some of you don't know. When I go to the NCLEX, when I look at your question bank, I can critique you based on what you say. If I'm seeing patient names, I know that this guy has no clue, or the person is using some AI to generate questions. And even your rationale tells me you're using AI. Telling the patient to sit down is crucial for. There are certain words AI uses a lot. If you are really somebody who uses AI, you get to know some of them. These questions were not handily worked on. They didn't take a nursing critical eye. So you, the nurse, sometimes you can answer a question, and then you see that no, for this answer there. But it's like you try to give in simply because they are authority. Sometimes pick the sounders, pick the hearsay, pick the Kaplan, pick those authoritative books, compare the answers. And if you are sure, kibosh what is in that question bank, throw it away. Not all of the questions will be bad. Some of them, they do also do continual renewal processes. And so you will see that sometimes they say, oh, we will be off for maintenance. Then they will do, it's not anything about maintenance, but they are changing the question. Some of the questions we've reported to them, and then they have to review them. It's as simple as that. Okay. My question bank is just $30 monthly. That's all. I don't charge much. It just, and even the $30, if you are paying from an African country, I'm not using the current dollar exchange. I've just have a flat rate for you, making things very easy because this thing is done for you. It's tailored to your needs. It's bespoke, and the accuracy 100%. We use the word client. We don't use the patient names, and we have a way of setting the options. Like you should have one correct answer, but three distractors. It's not. It shouldn't be two opposite direct definition. No. There are principles in doing it. So when I see the way they write the questions, I'm like, why are they doing this to take people's money? And of course, if you sit with, guys, sorry that I'm doing this. If you sit with one question bank continuously for 2-3 months, when you go on the NCLEX, because it's a genuine nursing thing, there's a probability you meet a popularized figure because it's a computer adaptive test. It uses some forms of intelligence. So no matter what, from the pool of question the question writers have put in there, you will get something synchronous. Let me ask my students a question. Guys, can you predict that you are likely going to get a question on diabetes on the NCLEX?
Yeah.
Yes.
On a scale of 1 to 10, how sure are you?
8.
9.
10.
Me, I'm 10. What about pneumonia?
It's 9. Yeah.
Yeah.
What about
Yes.
heart failure?
Sure.
Definitely.
Yeah.
So if somebody goes to write the NCLEX and comes back and say, Sabi, I don't know why you're not even telling your students to use this question bank. Hey, some of the questions I made, they were all there. It's not true, guys. They were not all there. It is just the central themes, okay? And our brains are not that retentive. We try, but I don't think anybody will be that brilliant to produce the exact wording. Even if it is the same thing that is there, the computer is smart to paraphrase. Do you know when scholarly articles have been in place? But up to today, when we are writing any scholarly paper, we are able to paraphrase it that it becomes unique, right? And so you don't plagiarize. Sorry to have brought all this in, but just to let people know what I'm giving them, what I'm offering. In the initial stages were the trial and error. That is why I gave it to you for free to try it for 2 weeks. Some of you saw evidently the issues with it. So you reported back and I refined it. So it's like a continual process. Even school IT department who have PhD computer technicians, I'm telling you, there will be times they will announce for maintenance. Guys, don't they do that?
Yeah.
Yes, things, technical hitches and other things do happen. Like today, I'm going to go and download some images there, ECG images. I'm sure it's going to spoil something somewhere. It will definitely spoil something somewhere. So I have to now go back to the questions, try them one after the other and see if all of them are okay. It's hard work, but I mean, it pays. So I'm just recommending to you, go and do it. Asacles.com, www.asacles.com. Try it for 7 days. If you try it for 7 days, you can try. And then with the computer adaptive test aspect of it, if you won't like it, you can use it. I've activated it for you. It can assess you. Just that when you start, you can't end. You have to answer all the 85 or so to the end. It has a range of about 85 to 125, and it will cut based on whatever you're doing, right? That was just a little bit about it. What was the answer to this question, guys?
It was C.
Which is
Yes.
C. C is correct. All right, let's try this question too. Don't forget about the nature of the stool. And I'm telling you, try and be part of successful teams and successful stories. I have over 1,000 people on my page. Each time I organize class, not even 10%, not even 5% join of my class, the number there. And when I even plead with them, like for example, I'm having a YouTube, you're on a page with somebody who is helping you out. He does free classes and all that. Just come subscribe for him. They wouldn't do it. They wouldn't do it. The video, they will not even come and watch it. Right? But they are with me. And the concept is that I'm very determined a person and I know where God is taking me. So if you better be part of the team and let's move together, right? Let's form that formidable team and move together because we are in this together. It's going to be a huge thing. I promise you guys that whatever we've started is going to be a huge thing. I'm not joking about it. And I'm not scared to start afresh. Yeah. So note that and then we move forward. I'm always being sincere and honest with you guys. Those on YouTube, just hit the subscribe button. Watch. It's a free class. Later, when you are free, you can come back and rewatch it. It's all credited to me as people liking the content that I do. That is how you can support without your money. And if you do it to a certain estate, YouTube will start paying me. And when YouTube is paying me and it's quite good, I don't think there is any. It's necessary for me to come and charge you for the class. I will just put the videos there and go and watch. Okay. All right. People chose A, C, and E. We will end the class here for today and look forward to your next class, which will be appendicitis, which of course you can never do GIT without. It's a high yield topic as far as the NCLEX is concerned. I'll pause here and allow members who have any clarification, questions, additions, anything to say to add. Are there any questions, additions? Or somebody saying something?
Yeah, yes, an appreciation for
Okay.
you. Yeah, yeah, so much beautiful. God bless you.
Amen. And I also want to wish every woman here happy Mother's Day. I did a YouTube.
Amen. Thank you, thank you, thank you.
You're
And
welcome.
same to biological.
Magical wife. He's listening. Today I did a video on TikTok, and the video was about each time we get to stages or states like this, we wish women. People post pictures, videos, long messages, short messages of all types. But there is always this category of women who, by virtue of their biological orientations, can never give birth. Others will not give birth because they've undergone some medical procedures. Illness brought them to that far. Others are not going to give birth because they are with a husband who cannot get them pregnant. But because of faithful issues, they want to be faithful to that husband. They will stay there and they will not give birth. As I'm talking to you, like I said in the video, somebody has just been told that she has menopause. Why? Because her blood has ceased flowing for about 12 months now. It is not an easy task. So each time we are wishing people happy Mother's Day, how do those people feel? And then my question was, do we wish them too? And if we are wishing them, what are the exact words we should tell them? What shouldn't we tell them? And is it true that when we say it, it puts them into some sort of thinking? Or is it that they've already accepted? So at the end of my video, I said, if we do an introspection or we collectively give our reasons and say, okay, no matter what, they deserve to be wished. Then I brought my message to them that I wish them well in their life. I wish them good health, good life, prosperity, blessings, happiness. Because some of these women biologically might have not given birth, but they fed villages. Some of them has raised cities. Others are keeping churches. And I'm telling you, because of some of them, some nations are going to be saved. There are wonderful women out there. And I mean, it's just a lot. We just love you guys. And we pray that whatever your heart desires, it's been granted unto you. That is what we will say for now. Thank you for coming to my class. And I hope to see you next time for the next class.